Good evening. I'm Kelly Gear-Ripken, National Chair of A Women's Journey. On behalf of Johns Hopkins Medicine's A Women's Journey, thank you for joining us this evening for our monthly webcast series, Conversations That Matter. A Women's Journey strives to improve your well-being through health education. According to the American Cancer Society's Cancer Facts and Figures for 2022, more than 1.9 million new cancer cases are expected to be diagnosed in the US. Approximately over 600,000 deaths from cancer are expected in the US in 2022, which is about 1,700 deaths per day. Tonight, we are pleased to be joined by radiologist Dr. Elliot Fishman, who is a professor of radiology, oncology, surgery, and urology, as well as director of diagnostic imaging and body CT at Johns Hopkins Hospital in the Department of Radiology. So please use the Q&A on your screen to ask your questions to the doctor who will respond during the last 20 minutes of tonight's conversation. Our webcast will conclude at 8 p.m. I want to take this opportunity to acknowledge and thank Johns Hopkins University's program, Hopkins at Home, for their production assistance, and you can visit their website for additional lectures and courses throughout the year. And now I'm pleased to welcome Dr. Fishman.
Okay, thanks very much, Kelly. It's an honor to be here. And hopefully I'll share with you guys some good information tonight. And what I'm going to try to show you is kind of where things are and where things are going. And so I'm going to work with doing at Hopkins. So what I'm going to show you is actually what we're doing. So hopefully that'll help a little bit. When you think about early detection of cancer, we've always been doing that, right? Whether it's a physical exam or it's clinical studies like a colonoscopy, whether it's looking at blood or urine, or radiology studies, be it mammography or screening chest CT, we have been doing screening for many, many years. The difference is as we go forward over the next several years and through the next decade, the things that are going to change is what we can do and the ability to detect things ever earlier and potentially do them non-invasively, whether it's lab tests, something called liquid biopsy, where you can look at blood and pick up early cancer well before it's clinically detectable, or it's radiology studies using AI. And I think you hear lots about AI in the world, and I'll just show you 3 slides that in some ways will make you think about what happens. When you look at imaging, whether it's mammography or CT, any imaging study, we try to be perfect, but the reality is you never are perfect. 3 slides. This patient unfortunately had an imaging study. They thought the breast mass was benign. It really ended up being cancer. This doctor, Regina Barzilay, who's an expert in AI, has been working and trying to change that. She herself had breast cancer, and she was looking at ways of using AI for early detection. And then if you look at the 3rd slide, this was another article published all within a few weeks of each other, that this company, and I have no conflict with this company, was able to detect cancer that the radiologists would routinely miss. So one of the things that is changing is we're using computers with AI to be able to detect things earlier. This is just one of many studies using AI, for example, on mammograms. They were able to be substantially more accurate than every radiologist. So one of the things we're trying to do as a radiologist, I'm not trying to put myself out of business, but I think if you look forward in the future, it's going to be how can we use technology to do things better, be more accurate? And that's what we'll speak about tonight. So if I just go back a little bit, roughly 50 years, CT was developed, Jeffrey Hounsfield. Many of you know the stories. It was a company called EMI. And the real fame for EMI was the Beatles, right? They made all those Beatles songs in the early 60s and mid 60s, but he developed CT, and CT went from a study that took 2 minutes for a slice to where in 2 seconds we can scan the patient today. If you think about it, when we first started doing CT, you always get slices of a patient. It would take you 50 minutes to do a study, and you would have maybe 30 or 40 slices on film, which we don't even have anymore. The resolution was limited. I fast forward to today, when I look at an average patient's case, I'm looking at 2,000 to 5,000 slices that's acquired in literally 10 to 30 seconds. On any one of those slices, you could see the findings. And so it makes it a challenge. If you think about it, here's just simply a CT scan where I did 3D reconstructions of the lower leg. You can see, depending on how I look at the information, I could see the blood vessels, I could see the muscle, I could see the bone. So you recognize by looking at those small vessels how good we are at being able to get really fine resolution. So our resolution is sub-millimeter. So the ability to see things is really there. The challenge is, how could you do it? The one way I've thought about it, all of us have looked at those Where's Waldo books. And the thing about Where's Waldo, in many ways, it's how you look at a CT scan. It's possible that patient is normal, and it's possible the patient has some pathology, something present. You have to look at the entire image, and hopefully you see something that is wrong if it's there, but it's a challenge. And when you look at the Waldo books, after you know where Waldo is, you always can see Waldo. And so we try to, as radiologists, as physicians, we try to get really good at reading the scans, but at the end of the day, we're not perfect. And that's where AI is going to come in, the ability to improve what we're able to see by being able to get around all of the noise and find out what's important. If you ask me the question, how often do you miss things? And this is not how often we miss them at Hopkins, because at Hopkins, of course, we don't miss anything. But in all seriousness, articles have basically said that between 15 and 30% of findings are missed on a scan. That's a lot of numbers, right? You want to be 99.9% accurate, but the reality is you're not able to. So we need to figure out better ways of doing things. And so when we talk about CT, we've been looking at axials and reconstructions and some 3D imaging. But as we are working now, we're looking at all sorts of different things, ways of improving image quality, ways of looking at the information in a different format where the computer can see things that a person could not, and then taking all of that information and being able to train. So I'm going to share with you how we do that. So here's just a simple image. We've been working on 3D for 35 years. I actually started working with Pixar. Most of you know Pixar movies, but what you don't remember probably is that Pixar was not made to make movies. It was made to make computers. They were the computer graphics group of Lucasfilms, and they unsuccessfully came up with a computer to do 3D imaging. And then after about 6 years of losing money, Steve Jobs said, okay, let's make movies. And the rest, as they say, is history. But if you think about it, here's a CT. Here's 2 sections of a scan through the abdomen. That's the pancreas, that's the liver, spleen, kidney. And if you look at the pancreas, there's maybe something at the very end in the tail of the pancreas. But what we're able to do is take all of those slices, instead of looking slice by slice, we look at things as a volume. And this is the same reconstructions. You see the pancreas here? You see there's something at the very end of the pancreas? And when I look at this image here, you see this white mass? That's a 1 centimeter cancer. Okay, typically or commonly that's missed. But you can see when you look at the texture, it stands out really nicely here, or it stands out here. So it's the same information. For the patient, there's no additional radiation dose. There's no additional time on the scanner. Everything you see here is done by the computer after the patient is long gone. And you can see in this image here, that's the liver, that's the pancreas, kidneys, bowel. You can see all of that on a single image. Or in this case, people make the comment, and it's been written in many articles, that between 30 and 40% of pancreatic cancers are missed when the patients first present. Remember, pancreatic cancer, we talk about a 5-year survival of under 10%. But the reality is, if you could pick up early cancer, survival is 70%. It's all getting the patient to surgery early. So with the same technique, look at this set of images here. So instead of looking for a mass, we look for texture change. This is the pancreas, but you see this part right here, how the texture looks different? Or over here, and I'll just circle it for you. So we're able now to pick up changes in texture. So the computer accentuates the difference between normal and abnormal tissue, which allows us to see things that perhaps would go undiscovered in the past. And we're able to look at things from any plane or perspective. Looking in the volume allows us to be much more accurate. And depending what articles you look at, things like this could increase detection rate between 10 and 30%. So it can be very important. Also, we use the same techniques. Here is a view of the patient. That's the aorta, the main blood vessel. Here are some of the other blood vessels that are very critical to determining whether a patient is resectable or not. So we're able to be more accurate, and it also allows the surgeon to plan precisely what they're going to do for their patients. So again, better outcomes always follow more information. We also are looking at things like the Hololens. A lot's written about, doing this augmented reality, and people talk about mainly for games, for playing video games, but the same technology is used. So we can look at the liver, we can look at the blood vessels, we can look at the pancreas. Now, this is simply me taking screens when I'm looking. That's my finger moving the case around in the middle of the air. So you're able to look at things with augmented reality, which will help you. So again, you think about it, we've gone from slices to volumes. We're able to look at everything at one time and get more information. And it's being able to do things like this, which translates into better accuracy. Now, other things we're working on. When any one of us, myself or anyone, looks at an image, you're looking for changes, size changes, texture changes, but there's only so much information you can actually pick up with human vision. Something called radiomics is a way of looking at the information, but having the computer analyze the information. And we train the computer to show what tumors look like, what normal tissue looks like. And then the computer can simply look at the images. And even in retrospect, I still can't see anything, the computer can pick up the tumors. So radiomics is simply AI. It's mathematical formulas being able to look at data and get critical information. Now, what it really does, and maybe this is a good way of thinking about it perhaps, is that it looks at the tissue, finds the abnormality, because what it does is it creates basically a ID. It shows what does a normal pancreas look like and what's the fingerprint for cancer. So the ability of the computer to pick up what doesn't belong will accentuate what we can do. And in fact, we published an article on this, and our accuracy for picking up cancer was 99%. So substantial difference. And there's been articles published recently where you go back and look at scans that were red negative, and you could pick up cancer anywhere between 3 months and 3 years before the patient presented and was diagnosed. So that's very exciting. Again, it's simply looking at features in the data, no additional radiation, no additional tests for the patient. It's simply the computer making decisions. So again, 99% accuracy, and this seems to hold up on multiple different studies from other institutions. We then take the next step, and what we've done for the last 5 years working with the School of Engineering and Radiology and Oncology and Pathology and GI at Hopkins, working on building AI models to be able to detect pancreatic cancer. And again, you're using the basic supercomputers, developing software, but the goal is to be able to detect things early. Well, what do? The reality is when you do computers and AI, you first need to teach the computer to be like you. That's what you're really trying to do. only be better than you. So what we spend time is literally, we looked at thousands of patients and we literally by hand drew the different organs. So here would be the liver. This is the pancreas in yellow. That's the stomach. That's the kidneys. And then what we did is we taught the computer. So the computer learned to be able to look at a scan, and that would be me drawing the liver, the stomach in green, the spleen in red. And the computer then became as good as us. So the computer can find all the organs. And then our goal was to find pancreatic cancer. So here was the computer, here was a regular image. That's one of us drawing the pancreas. That's the computer predicting the pancreas. So you can see the computer is as good as a radiologist in finding and outlining the pancreas. We then taught the computer very much the same way, except now we taught the computer, how does a cancer look? One of the things you have to remember with AI, it's artificial intelligence, but in order for AI to work, you got to teach the computer what it is it needs to be looking at. So we taught it, what does cancer look like? What's the range of cancers, small and large, the various appearances. And then by the end, here's what happened. The computer, red is the tumor, this is the pancreatic duct, purple is the pancreas. The computer is able to look at the scan, find the tumor, outline the pancreas, and be precisely as accurate. Now, that's a larger mass, that's about 4 centimeters, but here's an image or 3 different images from a few millimeters to a little over a centimeter to 1.5 centimeters. That's the computer looking without any physician intervention and finding the tumors. And that's why AI is so exciting, the ability to see things and pick up smaller tumors. Again, accuracy is what you're looking at. Can we increase accuracy? And then things we're also doing, I showed you the radiomics, which is kind of fingerprints. Now the ability to combine the radiomics with the deep learning, again, the idea, early detection of things that we can't see so that we can intervene on patients even earlier. Now, one of the things that's also happening in the world of computers is we're learning how to do things better. So here's a simple example. This is an article published from Hopkins. It involved multiple institutions around the world, and they looked at pancreatic cystic lesions. About 7% of the population has pancreatic cystic lesions. It's more common in older patients. Pancreatic cystic lesions can be a predictor of developing cancer. The problem is only about 3% of patients will develop cancer. So that's 97% of the time, it's nothing important. Sometimes it's easy to predict, but many times it's not easy to predict. So there was a study done, about 850 patients, and the accuracy of the best surgeons around the world and GI people at predicting who should or should not go to surgery was 40%, only 40%, which means that 60% of the patients went to surgery for no reason. Okay, now that was the best we could do. On this article, this was by Emery Lennon, Bert Vogelstein, they were able to develop a program that could predict with an accuracy of 60%. Now, 60 is not that great, but 60 to 40 is really good. The good news is that we've been working with Microsoft for the past 8 months. Microsoft has a division called AI for Good. It's totally philanthropic. So they've agreed to work with us at Hopkins for the next 2 or 3 years. And they develop some different programs. You know, when you talk about AI, people often criticize AI because they say it's a black box. We don't know how it works. We're scared to use it. One of the things that Microsoft has been able to do is make this something called EBM, explainable boosting machines, which is more like a glass box. So you can look at why the computer comes to a conclusion. We could look at all of the different factors that the computer thinks about when it makes a decision. And I mentioned to you 40% accuracy. The first program was 60%. This program by Microsoft is over 90% accurate. So that would be just spectacular. So we're actually doing more work on that over the next couple of years, but just a tremendous opportunity. Now, if you look at AI in the big picture, everything that, there's a lot of work being done at research institutions. But at this point today, there's over 300 applications that have FDA approval. So it's a rapid succession of approvals for different things. Now, a lot of them are to assist the physician. At this point, very little is being approved that's going to replace anybody. That's really, we're not quite ready for that. But just to show you simple things, here was a product, and again, we have no conflict of interest with any of these companies, but there was a company, patients go to the emergency room and they get a head scan because sometimes there's suspicion of a bleed, or maybe they had trauma. And what happens in a typical ER, they're very busy, and you get to the images, usually takes about 40 minutes because a lot of patients are before you. What they developed was a technique that looks at every head CT. It looks for blood. If it sees blood, it moves it to the top of the list. So for the radiologist, you're going to have to read the study eventually, but now I'm reading it instead of 45 minutes, I'm reading it within 5 minutes. And remember, if you have a positive bleed, brain is time, everything is time. So the ability to move things up, and the accuracy was very high. And if you think about it, even if the computer was wrong, all you're doing is reading it earlier than later. So what's the downside? But the accuracy was super high. And in fact, on a lot of the time, it picked up bleeds that the radiologist, when you did other studies, would have missed. So tremendous opportunity. This was an article talking about bladder cancer treatment, okay? Now, it would make predictions. AI would look at the information and help predict based on the imaging for staging. Now, what's really important about this, and when you start looking at AI, one of the things it shows is that it really experienced people, and maybe the world's best people, it only improves them a little bit. But for the average person, it improves them significantly. So one of the things you find out is that it really raises all boats. And so people who aren't as expert become basically experts. So physicians from multiple institutions and multiple specialties become better. So in looking at bladder cancer, the people who had limited experience, their accuracy might increase 30%. Someone who had massive experience, maybe 2%, but it made the inexperienced people as good as the best people. And places like Hopkins, our job is to train people that everybody, everywhere in the world, everywhere in the country, not just in Baltimore, gets the best care. So AI seems to be a great equalizer, improving the standard of care for diagnosis, improving particularly for the least experienced clinicians and making them experts. And most importantly, it improves the likelihood of a better outcome for all of our patients. This was an article looking at chest x-rays, okay, and looking for diseases, the same thing. They trained it on 54,000 cases, so not insignificant. But look at the results. The algorithm outperformed physicians, including radiologists. So it was better than the people involved. And at a minimum, with FDA's approving, is not to replace the clinician, but to have basically a second reader. So it'd be like someone sitting with you, helping you find all of the things that are abnormal. So it's very, very important. Again, you can see from that article, people would miss far less things. And so if you're looking, for example, detecting lung cancer, it could improve detection by 30%. So again, really significant numbers. Now, that all sounds good, but for many years now, you've all heard about driverless cars. They were coming any day now. And I know they will get here, but it's never as easy. If Jensen Huang and NVIDIA speak about driverless cars, and they said, look, if everybody was on a racetrack and everybody was in a driverless car, there would never be an accident. The problem is when you're doing a driverless car, someone's going to cross the street, someone's going to go slower, someone's going to come with a bike. Things are going to happen that are unexpected. The question is, how do you make things so well that all of these variations don't impact the outcome? So the challenges are really reproducibility of the results. One of the things you often see with AI, somebody will say, oh, I have 90%, 95% accuracy, but they've looked at 100 cases from their hospital. Well, the second you take another hospital or a different group of patients, it doesn't work. Sometimes studies are designed to solve a very limited problem. There's a challenge because of HIPAA getting data sets. One of the challenges, for example, is getting data sets of patients of all different races, of all different ages, to get the computer to train on all those data sets. Computers learn very well. There's a good article written where computers were trained to look at skin lesions and be able to detect whether the lesion is malignant or benign. And they had, one of the first articles published was 99% accurate, which is amazing, right? But the thing that happened was, when you look back at the data, if the dermatologist thought it was probably cancer, they put a ruler on the picture. So if the computer only said what pictures had rulers, it would be 95% accurate. So again, often at times that was unintended, but things like that can indeed happen. There's lots of different ways of being able to try to get around bias. Large data sets become very critical. And again, it needs to be done in a very, very user-friendly way. I think one of the things, when you think about things that work in medicine, it needs to work for the patients and it needs to work for the doctors as well. I mentioned radiomics before. The results are very promising, but the second you get more data sets, it may often not be as promising. There's a lot of reasons. There's biases, which are unintentional, variability in terms of the scanners you use, how you acquire the data, how you evaluate the model. So one of the challenges looking forward to AI as we look at the next few years is making certain that we get rid of the biases by increasing the quality of data and really testing it extensively across larger and larger populations. There's other things that are practical about AI, and this is just the reality of the world. You know, if you're using AI today, if I'm a radiologist reading a study, it's very clear that if I would read it incorrectly, I'm the one responsible. What happens when you have AI? Is it me responsible or is it the AI? The other thing is, if I'm reading a study and I think it's normal and the AI says there's something there, but I don't really see what it's pointing to, I can't find it, what am I going to say on my report? I think it's normal, but the AI think it's positive. I mean, how do you manage that? It's really a challenge. And then also, you know, I'm a radiologist, but, you know, a lot of these AI from companies like Google, for example, or NVIDIA, they have far deeper pockets than we have. Are you going to sue the company that developed the algorithm, or sue the radiologist, or sue anybody? How do you deal with liability? That's something that will need to be addressed, because no one is going to have a product in the marketplace if they're liable for everything that goes wrong. Now, in regular care, the way all of us are responsible, all physicians need to do what the standard of care is in the community. If you have AI, will it change the standard of care? One of the things that's a great question is, if you use AI today, and some people are, it's early in the game. When is AI going to be the standard of care? How do you know when, if you don't use AI, you're doing things incorrectly? And that's one of the things that are really going to, it's going to take a while to figure out. All of these questions become real challenges because, again, you want to do what's right, but when is the right time to do it? Now, you can also ask, what do patients think about the use of AI? I think at the end of the day, if you are uncomfortable with a doctor using AI, it's not going to happen. So I think one of the things we really need to do is figure out, how do we teach people, whether it's talks, how do we explain to patients how AI is going to help things, where it's good, where it's not good. Now, it is true, I don't think anybody wants to get a report from a computer without a physician in the way. I mean, all of you now can check your reports on the using one chart, all of those things like that. But when you ask people really what they want, people will feel comfortable with AI in specific settings, but more importantly, they want to know that AI is being used with their doctor, that their doctors are involved in the decision-making, that it's not a computer, no matter how good the computer might be. If I told you the computer is 99% accurate and the physician's 85% accurate, in some of the studies, people said, I'd rather have the physician. So just being super accurate is not always the answer. So how do we make people comfortable with AI? How do we make physicians comfortable with AI? It's a challenge to them. Again, how do we use it to optimize patient care? It's a really interesting thing. We talk about medical records. We went from paper records to things like Epic, but a lot of physicians weren't involved in choosing things like Epic, and it really became a hard time. If people spend more time looking at their computer than they spend looking at their patients. So it's going to be very, very important for us to make certain that it really works in the patient care. The good thing about it, from a radiologist perspective, let's say, or from any clinician's perspective, if AI makes you more efficient, if it increases your accuracy, then perhaps you can expect to spend more time with your patients. That's going to be the goal, not to spend less time and see more patients, but to be able to get away from simply looking at the computer and really dealing with patients. But again, if you can be more accurate, if the average physician can become an expert, it's going to be hard to argue that AI is not going to be the way to go. Now, if you look at AI, AI is just one part of the process. This is a busy chart, but I think it's a really good chart of thinking of where we're going. If you look at imaging, CT, MR, PET scanning, ultrasound, mammography, all of those technologies are improving in quality. Every year there's new developments. The scanners have higher resolution, they're faster, there's less radiation dose. All of those things are happening in the background. And then the computers now are being trained to be able to look at the time they acquire the data and look with AI to make sure you acquired the data correctly. It's taking a lot of work away from the technologists, or a lot of the work that's kind of guesstimated, and making sure you do the study absolutely perfect. But then there's other areas. I like to think radiology is the most important thing in the world because I'm a radiologist. But there's so much work being done with sensors. There's so much work being done with blood tests, biomarkers, and the like. So what you're going to see is the spectrum of imaging and lab tests all coming together. The way you like to think about things, the best way of having a good outcome, whether it's pancreatic cancer or lung cancer or breast cancer, everything is early detection. The question is, can we improve the early detection of disease? That's really where a lot of the excitement is. Picking up a tumor when it's spread to other organs, or it's really large, or it's unresectable, that's the bad time to pick up disease. And unfortunately, these days, for a lot of diseases, we pick up diseases when it's too late. When you look at pancreatic cancer as the one example, 80% to 85% of patients at time of presentation are unresectable. So only less than 15% of patients are going to be resectable. What if we can change that 15% to 50%? That would make a massive difference, because then you would increase survival from probably 7 or 8 or 9% now to somewhere around 35 or 40%. That early detection is critical. Looking at things like mammography for early detection of breast cancer, there's lots of variability in interpretation. It's not a perfect science. Not every radiologist reading the mammogram will read it the same way. There's lots of variability. There's a lot of work now that shows that computers are more accurate than radiologists. At this point in time, between 20 to 40%. And radiologists with AI can be the ideal scenario. And one of the things you'll hear about are things like liquid biopsy, where you're able to find where on a routine physical exam, just like you draw blood to look at your hemoglobin and hematocrit and everything else, you would look for early detection of cancer. The blood test may suggest it, and then the imaging will find it. So the ability of combining early detection with blood tests with imaging is really the way things are going. The other thing you have to think about with imaging is monitoring. I mean, many of you on this call probably have Apple Watches. Apple Watches collect all sorts of data. The problem is, it's really nice that it's collecting your pulse and your blood pressure and arrhythmias and all sorts of things. But unless somebody looks at the data, it really doesn't help. You know, when you go to your physician once a year for your physical, they measure your blood pressure. Everybody is nervous, particularly if you're a doctor, you're really nervous. So your blood pressure is high. But you think about it, your doctor has one time point, and that's it. But your Apple Watch is measuring your blood pressure every day. So what needs to happen is when the doctor sees you, he needs to see your blood pressure for 365 days, not for one day, or see your pulse, not for one moment. So all of this information, and that's where AI comes in, because AI can be monitoring the information. So whether it's lab tests, whether it's the smart devices, whether it's imaging, I think all of medicine is rapidly changing, because the ability to improve the care of all of our patients is really exciting. Now, it's hard to predict the future. There's no doubt. When I started doing 3D imaging 30 years ago, I thought within 5 years it would be widespread everywhere all the time. I'm still not correct. So you can't always be correct, but I think technology is really moving quickly. It's worldwide, from the US to Korea to China to Israel and every place in between. Every institution, every researcher looking at AI and the opportunity it provides for doing things better. We also talk about the cost of medical care. Early detection will decrease the cost of care because it'll provide better outcomes. There's a lot we know. I always like this quote by Donald Rumsfeld. As we know, there are the known knowns, the things that we know. That's easy. There's also the known unknowns. That is to say, we know there are some things we do not know. But I think what's very exciting, and I think where AI really is, in sort of these unknown unknowns, the ones we don't know. And I think in many ways, that's where we are today. I think we're sitting at a very bright horizon with really good opportunities for changing how we practice medicine for the next so many years. It's going to take some time. It's going to take some experimentation in terms of making sure the algorithms, not experimenting on patients, obviously, but making sure the algorithms work well, making sure we have the right algorithms, and then using them correctly in clinical practice. It's going to take time, but I think it's happening very quickly. You may have read in the paper last week that Google released this major platform that they've developed over the past decade for free to push AI in medicine. Okay, things like that are happening routinely. Many companies are doing the same thing. So I think it's very exciting times. And at the end of the day, whether you're a physician or a patient, all physicians are patients. Everybody is a patient. And I think for all of us, I think the next couple of years are going to be very exciting, because I think we're going to see massive changes in how we practice and how we can take care of patients better than ever. So with that, I'll stop there and go over to Kelly.
Great. Thank you, Dr. Fishman. Wow. What interesting information, and beautifully presented, I might add. I mean, it was terrific. So just in a nutshell, before we get to questions on just what you were talking about, lastly, so do you envision one day when AI will become a routine diagnostic tool, and perhaps liquid biopsies as well?
Yeah, I mean, answering the second part first, liquid biopsies, there's two big companies, Thrive and Illumina. Both of those companies are doing trials. They're being fast-tracked by the FDA. And potentially those things can become literally in the clinic within 3 to 3 years. So I think that's coming along. AI is being used at a number of different places now. I mentioned this application for looking for early bleed. Many hospitals are now using it. So more and more hospitals are using some of the early AI stuff. Again, it's not replacing any physician or radiologist, but it's improving the quality of their care. And as I mentioned, there's literally over 300 FDA. There's an application. There's actually 2 applications that are actually reimbursed. One of them is to look at the spine to detect osteoporosis, which is commonly missed early. So a lot of the things now are being approved and they're being put into practice. So, it's starting already. I think it's a matter of how fast and how many applications are there.
Right. Besides those two, AI and liquid biopsies, do you see anything else on the horizon?
I think, I mentioned about monitoring, the Apple Watches or the equivalent. I think that's going to be a very big thing. I think, I heard someone give a talk and they made the point that when you go to a physician's office, and like I mentioned, you're there for a visit, in a few minutes, they have to figure out everything about you since last year, and they really can't. When you have so many, at CES, which is the main computer electronics show, when I went pre-COVID, half the stuff they were showing related to patient well-being. So for example, whether it's your refrigerator showing you what foods you should eat and what you should not eat, making your home the center of healthcare. All of those things I think are coming along. I think I think every part of, every part of everything we do, AI can fit in, whether it's driving correctly to eating correctly, whether for diabetic patients, non-invasive ways of monitoring their glucose levels so they can be, they have these new pumps, they use AI to determine when to give insulin. So I think every aspect of what we're doing, from cardiac valves being designed and being monitored, all of it, I think everything we do is going to change.
Yep. Well, let's hope so, because this is amazing stuff we're talking about. So with that, we're going to jump right into a question from Sharon, and right off the bat, which is a really great question, is the use of AI, is it covered by insurance?
Actually, as I mentioned, there are 2 applications. One is on a cardiac app and one is a spine. Those 2 are covered. They're the only ones that are covered. But I think at this point right now, because AI is so early, the places that are using AI aren't charging for you to use them. So for example, the app I mentioned where, it moves things to the front of the queue for possible bleeding, no one is charging for that. So I think at this point, it's a little bit early in the game. People are using it to help them. I think one of the things also people are hoping is that, radiologists, technologists are in short supply. It's felt that if you use certain types of AI, you can improve productivity by 30%. So if you can improve productivity by 30%, you may not need to charge anything because you'll be able to do it that way. But right now, insurance is looking at AI. I think since it's not, insurance tends to pay for things that are standard of care.
Sure.
AI is not yet standard of care.
Yeah, it's going to be. We'll be positive about it. Our next question from Laura, it's still with the cost, but is there a risk and cost that too much unnecessary imaging will be done? So what are the criteria for using AI?
Yeah, actually, in many ways, I think using AI, you get right now, you get a scan and someone looks at it and hopefully they find if there's anything wrong. But sometimes, I mentioned with pancreatic cancer, the first scan missed the findings. You couldn't see it. And you end up getting another scan, and finally something's detected. I think AI has the potential for decreasing the cost, because the way to save money and to save lives is to make the diagnosis on the first scan. So if you can optimize the quality of studies where people don't miss things. I mentioned that a lot of the apps that are being used now, it makes somebody who's an average physician into an expert. That'll save a lot of money, right? Because if the first person doesn't diagnose it, they send the patient to somewhere else, they get more testing. What if the diagnosis is made the first time? So I can look at a world where AI will decrease the cost of medicine by making the diagnosis earlier on less studies, less expensive studies, and then people will get care earlier where care is cheaper because you can really optimize at that point.
Sure. Great. Thank you. Our next question is from Betty. Is this available for early detection of childhood cancers? Great question.
Yeah, there is work going on. I've seen work going on for, there's a number of things AI has been used for in pediatric patients. One, AI right now is more accurate than physicians in determining bone age. Okay, that's a relatively simple thing, perhaps. There was just an article published that AI is better than physicians at detecting fractures. So you're looking at trauma, whether it's a wrist or it's a car accident. The accuracy of AI compared to the physicians, surely non-radiologists, but even radiologists, can be anywhere between 10 and 30%. So in pediatric patients, there was just an article literally last week. There was an FDA approval of an app for detecting fractures in pediatric patients. People are also using AI for different tumors, liver tumors in pediatric patients, for example, also looking at the lungs for detecting lung metastasis in pediatric patients. So it's a little bit trickier in peds patients. The sheer numbers of cases trying to get is a little bit harder, but there's a lot of work going on in that arena as well.
Great, thank you. So our next question from Joan, she'd like to know, are there other applications for AI in medicine besides the cancers?
Yeah, well, I mentioned fractures. So the simplest thing, a really simple thing is, places like Hopkins, we have radiologists sitting in the ER. Most hospitals you go to don't have physicians overnight, radiologists overnight. And so the ER doc will look at the images and hopefully they'll be correct, but probably often not. And then the next morning, patients will often be called back. It's been shown that AI can be used for detecting fractures. There's FDA apps that are approved for looking just at wrist fractures. There's other ones now for detecting fractures anywhere in the body. So you can imagine something as simple as a fracture can be, it's often missed initially. The patients are discharged. So that's really one very good example for picking up. The other thing that's really been shown to be good, AI is used on chest x-rays for looking for pneumonia. So AI is really accurate. So one thing in England, for example, they're very short on radiologists. So within the last 2 years, they've been backed up for 8 months. If film wasn't read for 8 months, you could imagine how bad that is. What's the purpose of taking it? But AI, there's a company called DeepMind, which is part of Google. Their accuracy of separating normal from abnormal is 99%. So it looks at every film. Everything that's normal goes to one bucket, and it's read normal per computer. Everything that it reads as abnormal, the radiologist reads. So it speeds up triage. I think one of the things that AI could potentially do, like I mentioned with the brain for trauma, fractures, pneumonia, is speed up triage. You can basically make decisions. People are using AI now. If a patient's in an ambulance and you worry about a stroke, in the ambulance, they will make the decisions whether they should start the medication, whether the patient needs a scan when they get in. So you're going to be, by the time the patient hits the ER, everything's going on. And now you also see scanners, both MRs and CTs, being put in ambulances. So there's even less time. So everything is being done remotely. By the time the patient hits the ER in 15 to 30 minutes, everything can be done earlier. And particularly with stroke, early intervention makes all the difference in the world. So I think we're speaking about AI for cancer, early detection, but I think every part of what we do, from routine physical exams, looking at colonoscopy, things like that. People talk about colonoscopy, that you're supposed to at age 50, go for colonoscopy. But and that's the way you pick up early cancer. But if you get down to the numbers, even the best colonoscopists are only about 80 to 85% accurate, which
Right.
means you could miss 15%. Is
Mhm.
now there's been a couple of programs and tests done. I think there is one with FDA approval where it actually looks at the images with the endoscopist and
Mhm.
increases the accuracy to nearly 100% because it's like a second set of eyes. So the endoscopist is looking and the computer is also looking. And I think that's really where I think AI is going to be the strongest, where it's not you versus AI. I don't think that's going to be the issue.
Right.
It's you with AI. I saw a very nice quote somebody wrote where someone says, is AI going to replace radiologists or AI going to replace physicians? And the answer was no. It will replace you only if you refuse to use AI. So the physician who uses AI will be very successful and their patients will benefit. The physician who doesn't want to use AI will be out of business.
Interesting. So that kind of leads into a next question from Anne when she's asking what percentage of the computer and AI is getting the cancer interception correct versus inaccurate?
Yeah, I think it's a great question because it's one of the things we're looking at. You know, most of it's interesting, but a lot of the studies, I know pancreas is one, lung cancer is one, very few false positives. I think that's what's very exciting because I did the equivalent of AI for looking at early lung cancer detection. So it would look at the CT scan and it would show you where it thought the lesion, where a cancer was. When I first started doing it, it would pick 100 things. Okay, well, that was a waste of time. If you put 1 million dots on the screen, I can't look at them. It's impossible. Now it's amazingly good that if it shows something, there's probably something there. It's the false positives are very low. If AI has a high false positive rate, then it's not going to be used. I think that's one of the challenges. How do you have a low false positive and the same time, you know, so you need to have true positive, not false positive. So I think that's coming along pretty well, but that always is the challenge. It's easy to find things if you're going to be not very accurate. If you're going to call everything positive, if I call every case positive, I'm surely going to be right.
Right. So our next question is from Meredith, and she'd like to know, so is the new technology being used to monitor the effectiveness of the treatment in cancer patients or to just diagnose new cancers?
Yeah, it's a great question. I think obviously one is the early detection, but I think people are, one of the things that we also are seeing, and remember I mentioned radiomics and I spoke about radiomics for early detection. Because we didn't have enough time to, I could spend the next 3 days chatting with you guys, but we are also using, and other people are, radiomics to not only detect disease like pancreatic cancer, but predict what chemotherapy you should use. So one of the things that's being done, often you might have 3 choices of what therapy to use. You try one, then you try the other, depending what works. Now you can predict which patient it will work on. So you can optimize the therapy based on the tumor. We also can predict patients' outcome long-term based on looking with AI. So I think AI is not just going to be detection, but it's going to tell you what the best therapy is for the patient, whether it's surgery or chemotherapy. If it's chemotherapy, what chemotherapy? Do you need radiotherapy? So again, gathering all of the information. I mentioned this work we're doing with Microsoft. What that's basically going to tell you, hopefully, right now, if you have a pancreatic cystic lesion, you need to follow it for 10 years minimum. We think that we'll be able to say, this lesion is not important. You don't need to follow it anymore. This lesion is important. You need to follow it very carefully, or this lesion is going to be pre-malignant. You need to take it out now. So I think,
That would be amazing.
Yeah, I think that's going to be really exciting. It's the spectrum of care that's going to change.
I agree. Yeah, all the way around. That would be wonderful. So our next question, we'll switch gears for a minute about CAT scans or CTs. So Ellen would like to know, is there concern about the amount of radiation from CTs?
Well, there's always concern. I mean, we want to have the least radiation to any patient. One of the good things is, over the past 20 years and continually year to year, the radiation dose is coming down. The manufacturers have really improved the quality of the detectors, the X-ray tubes. So the doses now are anywhere between 70 to 90% less than they were 10 years ago. Again, the best way of decreasing dose is only doing studies that are necessary. That's the first thing. And also, I always like to tell people that the way to save radiation dose is to get it right the first time. If you find the answer the first study, you don't need the second and the third and the fourth study, which often happens. So if you get it right the first time, that's the best way to save dose. But we are putting a lot of effort. And one of the things that AI is also being used for is making the decision what the right parameters are. When you get a scan, depending on your physical size, we can make decisions how much dose to give you. A larger person needs more dose than a smaller person, to have the same quality image. And we're pretty good at doing that, but you're still, I won't say you're guessing, but with experience, you get better at it. Now AI will look at the patient and determine based on size what the best dose is. So now AI gives you the optimal dose for that patient.
Right. So with that, Dr. Fishman, because it's been in the news lately, so you go in, you get a CT scan done, and they say, well, it looks like you're going to need to either get another one or perhaps, the usage of ultrasound. So how does the patient know really what's the way to go here with this?
Right. I think one of the things is, we have many imaging modalities, CT, ultrasound, MR, PET scans. Each of those has certain advantages for certain things. So for example, if you said to me, I'm worried about the gallbladder, every one of those studies can look at the gallbladder, but ultrasound is really, really good. There's no dose. It's cheap. It takes a couple seconds to do. If you tell me I got to look at the pancreas, CT is the way to go. So I think one of the things we try to do and what the clinicians try to do is figure out what they're worried about and then get the most appropriate exam. I think that's one of the things that's really the biggest challenge at times. We don't want people ordering 5 studies for patients. You order what you think is the best study, and we're working with our referring docs to really train them and saying, here's what we can do best. Sometimes you'll do a study and it won't answer the question, and you might need to do a second study. But you really don't want to say, okay, let me get 5 studies, and hopefully one of them gives me the answer. So you really want to triage patients for the right study, the right study for the right problem.
We've got about maybe 60 seconds left until so it's a quick question, but this is from Susan. Are there any trials that you can become a part of?
Well, there are trials. This liquid biopsy, for example, that trial is going to start, I think, early next year in many locations. So it's possible.
So not just at Hopkins, in other locations as well.
It will be at Hopkins, but this will be multiple locations around the country. I think even around the world, but Hopkins is going to be one of the sites that's part of it. And I think there are a number of different trials. I mean, depending on what disease you might have, you can speak to your physician. There are a lot of trials going on. One of the things that we do speak about is clinical trials are very important for reaching the right answers. And I think it gives the patient perhaps better care, but you get optimal care. So clinical trials, depending on your problem, it's worthwhile looking into. You can ask people at Hopkins. You can ask Kelly; she'll tell you where to go. You can look at the NIH. You can
ask your physician. I think on that would be your right. So unfortunately, Dr. Fishman, we've got to end. We're getting close to the 8 o'clock hour. We could go on and on, but I want to thank you so much for speaking with us this evening. And to the audience, Dr. Fishman has graciously agreed to respond to any of your unanswered questions that were asked this evening. So in a couple of weeks, you'll receive an email outlining the outstanding questions and answers, and we so appreciate that. In the coming days, a video of tonight's live stream will be available on the A Woman's Journey website, hopkinsmedicine.org/A Woman's Journey, under Videos on Demand. And if you've enjoyed tonight's discussion, please check out our website, hopkinsmedicine.org/A Woman's Journey, for information about A Woman's Journey. Also on our website, hopkinsmedicine.org/A Woman's Journey, you can register for our upcoming program on Saturday, October 29th, from 9:30 a.m. to 12:30 p.m. at the Baltimore Marriott Waterfront Hotel in Harbor East. You can join us in person or virtually. You can enjoy a healthy brunch and hear our inspirational keynote speaker tell her very personal, moving, and long journey from the effects of COVID. You'll also hear from 3 Johns Hopkins physicians about the latest information about vitamins and supplements, the relationship between music and memory, and symptoms we shouldn't ignore, which will be followed by morning rounds, as we're calling this, which will give you the opportunity to speak in person with an additional 14 Johns Hopkins physicians on topics that are just right off the cuff and very important. So I hope you can join us. And as always, you can visit our website, again, hopkinsmedicine.org/A Woman's Journey, to register for this special program. And for more information about upcoming webinars, our Insights That Matter podcast series, and sign up for our monthly email. So I hope to see you soon. Thank you and good night.